Good day, everyone. To present an interesting and dynamic topic, we've been in the middle of a pandemic for the past 14 months. We're learning a lot of, we've been having a lot of information. We're learning a lot of terminology by our colleagues. But one important aspect of this pandemic is that we have people that have persistent symptoms after having an acute infection. And these are people that are literally in the social media known as long COVID, or the Americans usually call them long haulers. So my topic is long COVID or long haulers, a reflection on evidence versus experience. I'm a family physician based in the northwest of the Republic of Ireland, and I have special interest in infectious diseases. The reason why I'm picking this topic is that, okay, we have learned a lot about COVID throughout this period, but still it has taken us 14 months. We're still talking about the persistent symptoms these patients have, and we yet don't have an adequate medical terminology to give to these patients. And we know based on the literature that most of the patients that recover, but we have some that still have symptoms after having the infection. And we know that so far, based on the Johns Hopkins Resources Center, there are 166 million confirmed cases of COVID-19, and the mortality rate officially it's 3.5 million, even though yesterday the WHO has given us a report saying that the number of deaths have been underreported, and it could have been more than 8 million people who have passed globally. Okay, so this is an overview of my presentation. I'll start with an introduction and with the COVID definitions based on the RCGP, the BMJ, the NICE guidelines, and the SIGN guidelines. And talking about the experiences, because this time doctors have become patients. And that's why we have to be healthy as doctors, because once we're healthy, we can treat and see patients or remotely triage and help patients in our community. And summary of evidence based on the research published in prestigious journals, and particularly management of post-COVID-19 cases in primary care. I'm going to specifically talk about primary care because that's my expertise, and I've seen patients having all these symptoms, and based on my experience and based on the information I have, it will be very great to share this with you and the take-home points and the resources that have based my presentation. Okay, as part of the introduction, we know SARS-CoV-2 is the virus responsible for the ongoing COVID-19 pandemic, and is an RNA virus, just like the SARS and MERS outbreak in 2002 and 2003. And we know that this has also affected a lot of people with severe acute respiratory syndrome. But in the case of COVID-19, we have learned that patients that are young with no any past medical history can result in prolonged illness and persistent symptoms, and not necessarily these patients that are admitted or have any past medical symptoms I mentioned. And some people literally, okay, based on the research, we have 10% in the community of people who have had acute COVID infections are more likely to have long COVID. And those who have been hospitalized and been discharged home, based on some research, from 80 to 87% have persistent symptoms that last weeks to months. We don't have any clear report or evidence on how these symptoms are going to stay, if they're going to stay for weeks or months. And that's why it's called the silent iceberg, because if you have a global population, okay, that's under a pandemic, and you have millions of people with the infection. So 10 to 20% of those who have recovered are most likely to have a long COVID. And this is something that we have to have in mind because we don't know how it persists, and we still have unknown evidence on how to manage these cases. And so the social media initially started giving these names, long COVID, long haulers, and it has attracted a lot of medical colleagues to come together and have a word about, okay, to have a consensus on a terminology. So as I mentioned, the NICE guidelines, the SIGN guidelines, that's the Scottish Intercollege Network and the Royal College of General Practitioners have designed a model, a rapid guideline, which has helped significantly clinicians working in the primary care. So one of the research that has attracted a lot of clinicians is the one done in Rome by Laminu Kaumi. This research has been published last year in the prestigious journal, Journal of American Medical Association. It was the first recognition of cases. You know, this was the first time people have gone to know that, okay, we have people that are suffering with symptoms, and it has really affected their lifestyle. It has really affected their health. So in this study by Laminu Kaumi in Fundación Politécnica de Roma, it has reported that 10% of the people who have COVID and are recovering in the community have persistent symptoms, particularly at least fatigue or difficulty in breathing. Whereas those who have been hospitalized and discharged, 87% of them had at least one or two symptoms, which I'll share with you in a graph. And at the moment, there are a lot of ongoing studies, a lot of studies in journals, in the Lancet, about COVID cases, persistent symptoms, but these lack a higher quality evidence. So that's why it's necessary. We have to recognize that we have patients in the community that will be ringing us and complain about these symptoms, which we can't ignore. This is like a summary, and it's very practical. And this was published last year by the Journal of Medical Virology in October last year. And it summarizes a lot about the pathogenesis or pathophysiology of the spread of COVID-19. As we mentioned, SARS-CoV-2 is responsible for the pandemic, and the transmission is usually through an infected person that exhales fine droplets or aerosol, or someone that's also contaminated surfaces and touches his eyes, nose, or mouth as mucous membranes. So it can spread to the lungs because the transmission is via droplets, as we mentioned, even though there are a lot of studies on the transmission, if it's airborne, if it's in a close environment, how it's transmitted, but still, you know, we don't have any quality of evidence to prove that. But based on the CDC and the WHO, the modes of transmission, as I mentioned, is this one. And once someone inhales, you know, the droplets or touches its mucous membranes, as we can see, it comes as a respiratory infection because it goes through the lungs. And this is like the vascular dissemination of the virus. So through the pulmonary vein to the heart, and then to the circulation, and it goes to the organs and tissues. And this will cause a dysfunctional homeostasis, causing multi-organ failure and death. In the right side, we can see how the virus can also lead to a pneumonic consolidation. A patient who has a respiratory symptom, fever, cough, difficulty breathing, and has bronchitis, and this will lead to a pneumonia to viremia through viral dissemination, and to the circulation, organs and tissues, dysfunctional homeostasis, and death. And an interesting part is here where we have the organs, because once we know that, okay, this goes to the organs and can pass to the host cells through the ACE2 receptor. ACE2 receptor is the same receptor where the SARS and MERS outbreak that happened in 2002, the report we have is that, okay, it also affects, it goes to the cells, to the host cells through the ACE2 receptor, and particularly through the, we have the receptor binding domain, the RPD of the spike protein. Throughout the pathogenesis, we'll be hearing a lot about the spike protein, which is very important. And once it goes to the cells, it affects, it damages the cells. I'll start with the brain, where we know most of these patients have fatigue, have neurological symptoms like the brain fog. So usually when the virus attacks the brain-blood barrier, it directly affects the nerves, which will activate microglia and astrocytes. Microglia and astrocytes are being considered as pro-inflammatory because they trigger pro-inflammatory states at the central level. And based on the reports, you can even have RNA transcripts in autopsies of patients who have died of COVID. And knowing this pathogenesis, you know that those that are also thinking about the treatment pattern of this virus, once you know the pathogenesis and the receptors that is involved and how it spreads, you will know ideally how to tackle the virus. And just last month, researchers from King's College published in the Oxford Handbook of Immunology the findings where patients that are suffering from long-term symptoms of COVID-19 will have a potential treatment pathway. And this was particularly this pathogenesis that they presented. So it's very new. And as I mentioned, we keep learning each time about this virus. So as we can see, Anthony Fauci and Dr. Tedros Ghebreyesus, these are people that have been significantly helpful in guiding us throughout this pandemic. Last year, Dr. Fauci mentioned that post-infection syndromes produced by COVID-19 resembles that of chronic fatigue syndrome or myalgic encephalomyelitis. And a lot of reporters were saying, okay, Dr. Fauci said that long COVID is CFS, it's not long COVID. So that's created a lot of controversy. And the same Dr. Fauci, in February this year, he mentioned that there's a syndrome, and this syndrome is the post-acute sequelae of SARS-CoV-2. So this has also has given confidence to a lot of physicians who have been leading this. And the World Health Organization called this as post-COVID-19 condition, where Dr. Tedros just April this year mentioned that it has impacted a lot on the individual, on the society, and in the economy. Talking about the definitions, this is a summary of definitions by this article, the Managing the Long-Term Effects of COVID-19, a summary of NICE signed RCGP guideline published January this year, where you have a patient with acute COVID-19 infection described as patient with symptoms for up to 4 weeks, whereas someone who has symptoms from 4 weeks to 12 weeks is being considered a patient with ongoing symptomatic COVID-19. And post-COVID-19 syndrome, which is very important to clinicians, and it has been very interesting, because once you recognize this illness as a syndrome, that is people that have persistent symptoms more than 12 weeks, and there's no any attributable alternative diagnosis. So in this case, you define this patient with post-COVID-19 syndrome. Okay, so here I have a summary. This is based on the long COVID group. The UK doctors who have had COVID have recovered from COVID. They had this published in the Lancet, where they also mentioned about what really affected most of them. during this tragic disease. And number one is the feelings of failure, because these have been people who have been in the front line helping a lot of people, and now they feel, okay, they have done something wrong by getting this virus. And they have this sense of guilt, the self-stigmatization, and they also presented with a lot of autonomic symptoms. That is, people telling you, okay, they have night sweats, people that have diarrhea, constipation, they're feeling cold, that's temperature dysregulation. And another thing is the orthostatic hypotension and palpitations. These have been very common in autonomic symptoms. We had cases of myocarditis and pericarditis leading to heart failure. We had patients with microvascular angina, with cardiac arrhythmias such as atrial flutter and atrial fibrillation, people with renal impairment, and new onset diabetes and thyroiditis. That is for the doctors based on the article published in the long COVID group last year. So from the patients, number one, debilitating fatigue. This is a fatigue that patients also describe it, okay, since they recovered, they're feeling weak, they can't do anything, they feel they have a lot of weakness, but they have this poor description, because someone will be telling you, okay, it's fatigue, you'll do all sort of lab investigation, and you'll not find anything. And this was number one. It was very common in patients. And affecting the brain, as we said, okay, there are some neuropsychiatric illnesses also affecting long COVID patients, like the brain fog, memory loss, and also people that had a reduced work schedule, people with anxiety, people with palpitations, insomnia. And these are just a summary of the most common signs and symptoms and presentation of my patients, and also based on the articles I've had published in these prestigious journals. We're also going to see that the summary of evidence, because I just mentioned the summary from patients and doctors. Doctors have become patients. So, and in this case, we have this published in the Journal of American Medical Association last year, as I mentioned, by Angelo Caffey, where 87.4% of the patients reported having persistent of at least one symptoms. That's fatigue, dyspnea, joint pain, chest pain, and cough. And another publication also by Greenhack, where generally 10% of patients experience prolonged illness after COVID-19. So what does the WHO say? As I mentioned, the WHO since last year considers patients with long-term effects of COVID as post-COVID-19 condition. And there's little known about the clinical cause of this illness. So, but it has emphasized on the rehabilitation and the self-management of the patients. And it has emphasized in the 3 R's. The 3 R is recognition, research, and rehabilitation. The NICE guidelines have something similar, just as I mentioned with the BMJ, the RCGP, and the SIGN guidelines. So the BMJ have these guidelines, which is practical, which is a summary, which is rapid, but still mention there's no definitive evidence based on recommendation. And the up-to-date also mentioned the systemic evaluation of the long-term sequelae of this patient, which is liking, but imagine. So this is like the summary we have, in this graph, we can see these are patients who have had COVID, and by the right, we can see the post-COVID-19 follow-up symptoms. And we've seen that fatigue, dyspnea, joint pains have persisted even after weeks and months of these patients. So another interesting research as part of the evidence published in the Lancet in January this year, where we had 1,733 patients. This was conducted in Wuhan, and it was the longest follow-up of post-COVID patients, which showed 76% reported at least one symptoms after 6 months of their illnesses. And these symptoms are fatigue, muscle weakness, sleeping difficulties, insomnia, anxiety, or depression. Pero et al. Also emphasized in psychiatric illnesses like fatigue as long time, and then depression, anxiety, brain fog, and these are all part of the new psychiatric illnesses that came with the post-COVID condition. Marshall and Cobb also suggested that it affects a lot of multiple organs. Even in mild cases, people can also have symptoms similar to chronic fatigue syndrome. Cavallo-Snyder also recommended a prolonged follow-up of patients. Cherry et al. Also concluded the dysgeusia, anosmia, and other dysfunctions are prevalent in even mild symptomatic form of this disease. We're also going to learn that in these patients where we manage in the primary care, we have to have a comprehensive clinical history of this patient. We have to support them with empathy, with good rapport. We also have to order some blood tests, like the flu blood count. In the flu blood count, we have to expect anemia. The kidney and liver function test also have to be also part of investigation. The CRP can be high in patients with acute form of COVID. The ferritin, the B type natriuretic peptide, this will be affected in patients with heart failure. The thyroid function test in patients with suspect with thyroiditis. We offer a chest X-ray in 12 weeks as well, also to see if there's any superimposed bacterial infection. So the division is two. We have a medical management and self-management. The medical management is symptomatic. If a patient has fever, we give paracetamol or ibuprofen, and we also have to control the long-term conditions they have. We have to listen to them with empathy. If they have superimposed bacterial infection, we give them antibiotics. And people that at home, we also have to give people that are 60 years or above, they can have their pulse oximeter, and they can daily use that. And it is very helpful in guiding us to know if the patient has any complication, such as pulmonary embolism, if there's any bacterial pneumonia, and all these are things that help, and if the patient also has other underlying conditions. So we also have to support them by asking them to have good diet, to sleep well, quitting smoking, limit the alcohol as well, to rest and relaxation. All these are very important. And then the safety netting, as I mentioned, we also have to give them this detail that if they have worsening breathlessness, if they have SpO2 less than 96%, if they have unexplained chest pain, if they have a new confusion or focal weakness, all this they have to call their general practitioners. And then rehabilitation is very important because these are people that have been in the hospital for a while. They're coming out. We have to assist them a lot by even having pulmonary rehabilitation, by control exercises they have to do at home. Even the exercises we have to give them, okay, they have to have a target, and they have to do it gradually. So the take-home points in conclusion, we have to know that there's no any definitive evidence-based recommendation for the management of post-acute COVID-19 syndrome. Most patients recover spontaneously, if slowly, with holistic support, right symptomatic treatment, and gradual increase in activity. Indications for special assessment, as I mentioned, those that have respiratory, cardiac, neurological symptoms that are new, persistent, or progressive. These are people that we have to refer to a specialist. People that have breathlessness, chest heaviness, muscle pain, palpitations, debilitating symptoms that are reported within months. And these are things that we have to have in mind when managing these patients. We also have to know that this affects a lot of people in our community. Over time, we need more research, we need more teamwork from our colleagues, and we need a multi-year studies to understand the situation. The WHO is working with experts to develop a clinical case definition of post-COVID condition, and a lot of countries have established clinics, long COVID clinics, where they've been managing a lot of patients with side effects, where they have respiratory specialists, cardiologists, nutritionalists, and it has really helped in managing this condition. Thank you everyone for listening. Stay safe and continue to maintain the protective measures, as you can see, to protect yourself and protect others. You can also contact me anytime. I have my email address there. You can also follow me on LinkedIn or on Twitter. And I'm very happy to present this presentation, and thank you for listening. Thank you very much.